So first, what is prosthesis? Before this, we previous speakers have spoken about the orthosis, various types of two types of orthosis, basically the of two segments of the body, the lower limb orthosis and the spinal orthosis. Now, moving forward, we are now I'm going to present the prosthesis about the prosthesis and of the lower limb only. So, what is prosthesis? First, it is not moving. Yeah. So, a prosthesis is an artificial substitute to replace the lost part of the body, both in appearance and function. In orthopedics, it is the replacement of a body part. That means basically a limb. But in case of dentistry, also prosthesis is there. But here, in case it is of a replacement of a limb. So, what are the objectives of lower limb prescribing a lower limb orthosis or lower limb prosthesis? It transfers the body weight. As we know, the function of it is a function of lower limb transfer the body weight and simulate normal locomotion, because the lower limbs is for locomotion. Now coming to the timing. When the prosthesis is to be given, because an amputation surgery, after an amputation surgery, when it is to be given, we can give temporary prosthesis immediately after the in the post-operative period with cast with pylon and foot attached to the pylon, and early fitting with custom prosthesis in 3 to 6 weeks, which reduces surgical swelling and wound start healing when there is wound is healing. And definitive prosthesis, of course, it is the last one, the final prosthesis. It is given 3 to 6 months, and when the limb matures and with minimum wound problem. And sometimes it may extend up to 1.5 years also. So when we prescribe a prosthesis, the determinants of outcome, the level of motivation of the individual, it is very important, because you can see many amputees moving without prosthesis using crutches, especially in cases of unilateral amputations. So motivation is very important. Motivation of the individual is very important, and also the quality of prosthesis. It is one of the important aspects determining the outcome. The prosthesis, you can, as we have seen in cases of orthosis, what is an ideal orthosis? Like that, here is prosthesis. In prosthesis must be comfortable to wear, easy to don and doff, lightweight and durable, cosmetically pleasing, must function well mechanically, and low maintenance requirement. And also, it should be easily available. Another determinant is the cognitive function and comorbid factors like cardiopulmonary status, trunk control, good upper body strength, static and dynamic balance, and adequate posture. So we need before prescribing a prosthesis, we need to assess the functional level of the amputee. That is measurement of the capacity and the potential of the patient to accomplish his or her expected post-rehabilitation daily function. That means, suppose a person of 20 years amputee, of 20 years of age, the prosthesis given to him will be different from a prosthesis which is to be given to a person of 60 years of age, because the functional levels of these two persons will be different. So we should see those aspects also. So what is the expected functional level that the person can achieve after giving a prosthesis? Then only it will be useful for the amputee. Otherwise, it will not. So we know all these levels of amputations in cases of lower limb amputations. So now coming to the foot amputations, partial foot amputations. These are the various levels, like small toe amputations. That is, the prosthesis given. Usually there is no requirement of replacement. However, some fillers can be put in the shoes or whatever he wears. Otherwise, functionally, there is nothing is required. In case of grade 2 amputation, whereas in case of grade 2 amputation, it because of these amputations, it reduces the push of force while during locomotion, while walking. So, resilient toe filler and molded insole with arch support can be given, or more, custom silicone rubber toes can be attached. These are the options for amputations of toes. Now, partial foot amputations, if rare resection and transmetatarsal amputation, shoe fillers or shoe modifications are given. We have seen various shoe modifications in those shoes, like similar to those. The shoes modifications of the shoes can be done in cases of partial foot amputation. Shoe modification includes stiff sole, spring steel shank extending to the metatarsal heads, and rocker sole or padding. A rocker sole or padding of the tongue of the shoe to help hold the hind foot firmly in the shoe, because in partial amputations, foot amputations, the available part, we have to replace the amputated part with these fillers. Transtarsal amputations such as chopper, Lisfranc or Boyd, the custom prosthetic foot with self-suspending splint socket, which allows a regular low quarter shoe to be worn. This can be used. And the posterior leaf spring ankle foot orthosis in another alternative, where in cases of transtarsal amputation such as chopper, Lisfranc and Body. I'm not using so much of, actually, I need to have provide some pictures, photographs, but I am not using so much of photographs because of the copyright issues. I could not find culturally free photographs of which can be used which have free cultural use. That is why I am not using so much photographs here. However, I'll try to explain whatever is available. This is, you can see a person with Symes amputation. The patient can stand easily. While in Symes amputation, patient can stand easily or walk on the end of the residual limb without wearing a prosthesis for a short household distances, because he has the heel pad intact. So there is no problem in bearing weight on the amputated and on the stand. So Symes prosthesis can be given, which are maybe a conventional type, Canadian type, or now newer types are also available. In conventional type, leather socket with anterior opening and modified with a modified sash foot, harnessing by less systems. Lasers are there. So here in cases of conventional, it is the sash foot is attached. I'll show you the sash foot later. Sorry, slide is not moving. Sorry, slide is not moving. Some problem with my system. Yeah, now it is okay. Yeah. Symes prosthesis conventional, and this, yeah. Now Symes amputation, Canadian, another prosthesis is the Canadian type of prosthesis, Symes prosthesis. Here the plastic resin laminated socket filled with modified, same as the previous one, conventional foot. The sash foot is here attached here. Extend it extends till the patellar tendon. Patellar tendon for leverage at the heel of the medial or posterior opening. Here the opening is medial or posterior, while in cases of conventional prosthesis, conventional Symes prosthesis, the opening is anterior. I'll show you the picture. This is the photograph of Canadian type of Symes prosthesis, where you can see the medial opening. Another one is the posterior opening. The leg, the amputated stump is inserted into the prosthetic socket from the posterior aspect of the prosthesis, and then it is covered with that part. Yeah, you can see the part. Yeah, you can see this one. This part is removable with the straps. It is fixed with the strap, and after inserting the foot into inserting the stump into the socket. So no suspension is required since the bulbous end serves that purpose. For a prosthesis to be kept attached to the stump, a suspension mechanism is required. But in cases of Symes amputation, Symes prosthesis, it is not required. It is no additional suspension mechanism is required because the bulbous end of the stump. On the other hand, newer socket design are where the expandable air suspension chamber inside the socket or thin removable expandable inner liner is attached. Now coming to the transtibial amputation. Conventional below knee prosthesis. Nowadays it is also called transtibial. It is called transtibial prosthesis. Previously it was called below knee prosthesis. Patellar tendon bearing prosthesis or patellar tendon supracondylar prosthesis. These are various types of transtibial, various types of prosthesis for transtibial amputation. Now coming to the components of patellar tendon bearing prosthesis. Foot ankle assembly. First is the foot ankle. We have to remember, we have to replace the missing part. So foot is not there because it is transtibial amputations. The foot ankle assembly is required. Next is the shank, that is the shin piece. Now the socket. Socket is the interface between the prosthesis and the stump. Now the last is the suspension mechanism, which will keep the prosthesis attached to the stump, residual limb, so that it doesn't go away while walking in the swing phase, right? Now this is a PTB prosthesis. You can see there are various parts. You can see the various parts. You can see the suspension cuff. That is the suspension cuff. That is the suspension mechanism. Now PTB socket. Next is the socket and the prosthetic shank in between, and at the lowest part, it is the foot ankle assembly. These are the parts these are the four parts of a PTB prosthesis. Again, it is problem.
Sir, escape first. Escape it and then move to the next slide.
Yeah.
So directly click on the next slide.
Okay. Yeah. Yeah. Now coming to the prosthetic fit. The prosthetic fit is basically basic functions of the prosthetic foot. What are the basic functions? Provide a stable weight-bearing surface, absorb shock in the stunt space of locomotion, replace the lost muscle function, replicate the anatomic joint, and restore cosmetic appearance. Now, what are the different types of foot ankle assembly? Sash foot, which is most commonly used. Jaipur foot. These are various types of foot ankle assembly: sash foot, Jaipur foot, Madras foot, single axis foot, multi axis foot, solid ankle, flexible keel, and dynamic response feet. These are different types of foot ankle assembly. This is sash foot. Most commonly used. Heel is made up of alternate layers of hard and soft rubber. Because of this, remember, this is non-articulated type of foot. There is no ankle joint available here, but the ankle joint motion, that is the plantar flexion, is simulated because of the texture of the heel. Heel is made of alternate layers of hard and soft rubber. So during heel strike, what will happen? This rubber compresses, mimicking a plantar flexion moment at the ankle joint. So it will simulate plantar flexion, but there is no plantar flexion, but it will simulate plantar flexion. So customized, it is cushioned heel compress during heel strike, replace plantar flexion, and forefoot dorsiflexion simulated by flexible toe portion. So in the toe portion, there will be the toe portion is flexible, so it will simulate little bit of dorsiflexion. And ankle dorsiflexion, actual dorsiflexion, inversion, and eversion are not there. There is not available in sash foot. So what are the advantages? It is durable, lightweight, little maintenance, excellent shock absorption, low cost, and also low cost. But there are some disadvantages also: inability to accommodate on uneven surfaces, not suitable to use by persons with high level of activity, heel cushion deteriorates, and lose elasticity. So there will be loss of plantar flexion simulation with time. And also it cannot be used barefoot. Now coming to Jaipur foot, it is, this is a very famous foot worldwide. It has different blocks. Ankle block is made up of layers of wooden pieces glued together. There is a carriage made of steel at 90 degrees. If you see internet, you can see you can go to the internet and you can see many pictures of the Jaipur foot. But I have not put it here because of the copyright issues. I have not put. You can use it, you can see it, but you cannot use for such purposes. So that is why I am not using this. So you can see it definitely. You can see those photographs in internet. Heel and forefoot block, microcellular rubber, protected by strong rubber shell and tire cord. It has 3 blocks bound together by nylon rubber cord, finally by cosmetic rubber in the upper portion, while the sole is carbon rubber compound. The whole assembly is enclosed in a die and vulcanized in an autoclave with 23 psi of pressure and 23 psi of pressure and 125 degrees centigrade for 30 minutes. And it will give you the Jaipur foot. So next is Madras foot. There are Jaipur foot. It has advantages, many advantages. I have not put it here. I am just speaking to you that the Jaipur foot has many advantages. It can be used barefoot. That is why in our rural scenario, it is very useful. It can be used barefoot, and it is durable. You can wash it. You can wash your foot. It appears like a normal foot. Appearance is also like an anatomical foot. And the heel, you can see one of the major difference between the Jaipur foot and sash foot. Sash foot, you can get sash foot of different heel height. That means you can use shoes with heels. With heels, high heel shoes also you can use sash foot with the different heights of heel. Sash foot is available different heights of heel, but in Jaipur foot it is not available. It is always flat. You have to use a shoe which is flat, or otherwise it is used barefooted. Another similar to Jaipur foot, Madras foot is there, which is extra, which has a extra rubber heel, shaped toes, shaped hind foot with tendo Achilles loop, sole covered with special tuberized rubber, colored like normal skin, can walk barefoot. It is similar to Zebra foot. Now coming to single axis foot. The previous all three feet were there were no joint there, but here single axis foot. That means the single it has a mechanical axis of plantar flexion and dorsiflexion limited by anterior posterior bumpers. It has axis of movement. It has movement of plantar flexion and dorsiflexion around an axis, single axis. Advantages: it is ability to reach stable flat foot in early stance, reduce knee flexion moment on prosthetic knee during loading response, and increases knee stability. But it has disadvantage. It needs maintenance because it has a joint, so it will need maintenance, and it has also increased energy cost. But it is used in transfemoral prosthesis. Multi-axial foot allows dorsiflexion, plantar flexion, inversion, eversion, and transverse rotation. But advantages: it is good for walking on uneven ground, useful to reduce torque forces on residual limb during stunts, more useful in knee instability, poor postural control, and in vulnerable skins also. But disadvantages: it is heavier, less durable, and expensive. Again, multi-axial foot, it has joints, multiple axes, so maintenance is more. It requires more maintenance. So it is one of the one example of multi-axis foot. It is another one. This is other one. All these are multi-axial foot with multiple axes of movement. Solid ankle flexible keel. This is similar to SAS foot but flexible anterior keel. So it provides limited inversion and eversion and transverse rotation. Again, here I can one thing I want to say again: the Jaipur foot. It has in Jaipur foot it has many inversion eversion also. Although there is no joint, it mimics little bit of it provides little bit of inversion eversion also, as well as plantar flexion and dorsiflexion like SAS foot. Here in this type of foot, solid ankle flexible keel, it provides limited inversion, eversion, and transverse rotation, lighter than multi-axis foot. It used for ambulation on uneven surfaces. It is also called as stationary ankle flexible endoskeleton foot. This is the picture of a solid ankle flexible keel foot. Now coming to dynamic response foot, it is energy stored in the foot at the time of heel strike and is returned to the amputee at the time of push-off. Higher walking speed here, the amputee can have higher walking speed. It is for more active for active amputee, jogging, sports activities. Examples are Seattle foot, carbon copy, quantum foot, flexible flex foot. These are lightweight but very expensive. Now coming to the prosthetic shank or shin piece. There are two types of prosthetic shank is available. One is exoskeletal, that is made of wooden hollow with plastic resin laminated on external surface. Advantage: it provides maximum strength, less expensive, but it is unnatural in appearance and texture. You can see this one. This is completely, this is made of wood and covered by laminated resin. Endoskeleton, it is also called modular type of prosthesis, modular shank piece made of aluminum or titanium alloy pylon and foam rubber, covered with foam rubber, which provides natural appearance and texture. It can be color can be over this foam rubber. The color can be given with like the similar color to the similar complexion to the person wearing the prosthesis. Advantage: it is lightweight yet strong, less energy expenditure, but the rubber covering deteriorates with time. So this one is the shin piece, that is endoskeleton type. Now coming to the socket. Socket is the interface between the prosthesis and the stump. So here the total contact PTB socket. Anterior wall extends up to the distal third of the patella and inward contour on the anterior wall. You can see it extends up to the distal third of patella, and inward contour on the anterior. You can see just below the upper trim line, there is a depression, that is inward contour of the anterior wall, that is called PTB bar. The medial and lateral wall extends proximally to the femoral condyle. Medial wall is modified with slight pressure on the medial flare of the tibia. The lateral wall provides relief for head of fibula. You can see from the medial side the same prosthesis, same socket. You can see the depression between the depression over the tendon, over the patellar tendon. Yeah. So posterior wall, again the posterior wall extends below the level of PTB bar. The posterior wall is designed to apply anteriorly directed force. You can see when you see a prosthetic socket, PTB socket, there will be an anterior depression and there will be an posterior depression. Anterior depression over the tendon, patellar tendon for weight bearing, and the posterior depression over the popliteal fossa, which provide a posterior anteriorly directed force over the residual limb at the knee joint, so that the patellar tendon rests on the patellar tendon bar, that is PTB bar, right? So again, the trim line, you remember I have told that the anterior trim line extends above the patella, upper third of the patella, up to the upper third of the patella, while the posterior trim line is little bit lower than that. Why? To give space for the thigh, the distal thigh portion. And also you can see there are two depressions on the depressions on the posterior part. These two depressions on the two sides, medial and lateral depressions, you can see on the posterior wall there are two depressions on the medial and lateral aspects. These are for relief for to accommodate the hamstring tendons, medial and lateral hamstring tendons. The posterior is designed to apply anteriorly directed force, right? You can see there are two depressions. Can you see two depressions? You can see two depressions here. So these two depressions, yeah, one is this one and another is this one. These two depressions are to accommodate the hamstring tendons, and you can see the posterior trim line is lower than the anterior trim line. Anterior trim line is here, anterior trim line is here, and well, the posterior trim line is here. This one is for to accommodate the hamstring tendons here and here, both medial and lateral. While this is for to give anteriorly directed force. Here this depression is anteriorly directed force at the popliteal fossa. Now these are the pressure tolerant areas. You know all these things, but while prescribing prosthesis, you should look for all these pressure tolerant areas, because these are the areas where the patient is going to bear weight. So these areas should not have any problem. That means like any sore, or it should have adequate sensation. It should not have any sensory deficit, these areas. So these areas should be examined before prescribing a prosthesis, all these areas, right? Again, these are pressure sensitive areas. Here, these pressure sensitive areas means here we should not give any pressure. These areas cannot tolerate pressure. So this is required. This is to be examined while with the prosthesis. That means while after wearing the prosthesis, you should examine the patient in these areas. After wearing the prosthesis for some time, if there is any chance of there is any sign of pressure application during the wearing during locomotion, so you should look for these things. Is there any sign of pressure, and if there is any presence of such signs, you should modify the socket so that pressure relief can be given, in these areas. So PTV socket designs, hard socket, it may be hard socket or hard socket. The perspiration does not corrode the socket. The advantages: the less bulky, easy to keep clean, reliefs and modifications can be located at exactness, worn with prosthetic shocks, with or without additional liner. But with soft liner, sometimes we prescribe the prosthesis with soft liner. Fabricated cover the modified cast to fit inside the socket and acts as an interface bed between the socket and the limb and provide protection and comfort. Patients with peripheral vascular disease, for thin, sensitive, and scarred thin and sharp bony prominences, and for patients with peripheral neuropathy, all these cases soft liner is required. And another socket is flexible socket made with thin thermoplastic material. Now coming to the suspension mechanism. These are various types of suspension mechanisms: slip suspension, supracondylar cuff suspension, supracondylar beam suspension, suction suspension, thin corset, thigh corset with knee joint, waist belt with fork straps. It is also called Y straps. I am not going into the details of these suspension mechanisms. Now, another type of prosthesis is bent knee prosthesis or kneeling prosthesis. This is advised in cases of very short transtibial amputations. But nowadays rarely used, because in short, the modern prosthesis can accommodate very short stump also. Still, sometimes it is useful. So for severe knee flexion, even for severe knee contracture also, flexion knee contracture also, it is given. TBL for weight bearing, but disadvantages are cosmetically not good, and gait disturbances and external knee hinges the clothing. The bent knee means here the knee is kept bent. That means it is flexed. Whatever flexion is there, if the patient can extend till to 90 degree, then it is kept at 90 degree flexion. But the only problem is the residual limb is projected posteriorly. So it may be visible from the posterior aspect of the person. Now coming to disarticulation, knee disarticulation, the socket is modified. Little bit modified. It is like socket of transfemoral prosthesis. It is similar to transfemoral prosthesis. The modified quadrilateral socket with some ischial weight bearing and soft socket liner with supracondylar build-up to provide suspension. The transfemoral knee unit, it reduce because knee already the anatomical knee joint. At anatomical knee joint, the femur, the end of the bulbous end of the femur forms the one portion of the joint. It is available already there because it is the amputation is through the knee joint. So the distal part of the femur is there. The condyles are there. So beyond that, you need to give the knee joint, the prosthetic knee joint. That before prosthetic knee joint, there will be socket. So the thigh portion of the amputee will lengthen. So it produces as much as 2 inch beyond the anatomic knee center. So it causes no significant, gait deviations. But sure, definitely there is a cosmetic problem is there. Poor cosmesis is there will be a poor cosmesis. So, but to some extent, it can be managed with a polycentric 4 bar knee joint. I will come to it while discussing the transfemoral prosthesis. The polycentric knee joint, it allows greater knee stability, a more symmetrical gait, and equal knee length when sitting. Although it is not be totally equal, completely equal, but however, it will come closer to the equal knee length. Now coming to transfemoral amputations, similar to the transtibial amputations, the same components: socket, suspension, knee unit, shank, and foot. Here, the additional part is the knee unit. Otherwise, the same. All the other components are there. Along with that, knee unit is more additional in cases of transfemoral amputation. This is a transfemoral prosthesis. You can see the socket, quadrilateral socket or ischial containment socket. Suspension is there. You can see the suspension, knee unit, prosthetic shank, and foot ankle assembly. These are two different types of socket. Shape of the socket, viewed from the superior aspect. You can see there are two types of socket. One is quadrilateral socket. Another is ischial ramus containing socket. The quadrilateral socket is you can see the this is quadrilateral socket. This is quadrilateral socket. You can see this is femur. This is ischial tuberosity. So this is quadrilateral socket. If you look it from above downwards, then the quadrilateral socket will appear like this. That means it is anterior posteriorly. The dimension is anterior posteriorly less and anterior posterior narrow, and it is wider in mediolateral directions. So there will be a seat over here, ischial seat over here. The weight is borne basically on the ischial tuberosity. More weight will be borne on the ischial tuberosity. Most of the weight will be borne on the ischial tuberosity. Whereas in ischial socket, ischial ramus containment socket, it is, you can see the anterior posterior dimension is more and the mediolateral dimension is very less. Ischium is contained within the socket. Narrow anterior posterior dimension in quadrilateral socket, while narrow mediolateral dimension in ischial ramus containing socket. So quadrilateral socket is most successful. It is most successful on long, firm residual limb with firm adductor musculature. It has narrow anterior posterior dimension, wide mediolaterally, weight bearing through the ischium and gluteal musculature at the top of the posterior wall of the socket, counter pressure from the medial third of the anterior wall of the socket fitted against the Scarpa's triangle. So when you see a quadrilateral socket, there will be a depression over the Scarpa's triangle, femoral triangle. You can see a depression over the Scarpa's triangle, and also on the medial side of the medial part of the anterior aspect of the socket, you can see another. There is an area of elevation. There will be a relief that is for to accommodate the adductor tendon. So counter pressure from the medial third of the anterior wall of the socket fitted with anterior against the Scarpa's triangle, which will keep the limb ischium on the ischial seat of the socket, and the lateral wall is contoured in desired degree of adduction and flattened. While in case of ischial containment socket, it is also called NASA. That means normal shape, normal alignment above knee socket, or CAT-CAM, that means contoured adductor trochanteric control alignment method socket. It has it is medial lateral dimension is narrow, as I mentioned earlier. It maintains normal femoral adduction because it is medial laterally, it is narrow, so it maintains normal femoral adduction.
Can you wrap it fast now?
Yeah. So femoral adduction and just yeah. Oh, it is yeah. Maintains normal femoral adduction and it enclosure of the ischial tuberosity and ramus gives better medial lateral stability. So yeah, I'll skip this one. Yeah. Now coming to the suspension mechanism, suction suspension is there, total elastic suspension belt, Silesian belt, and hip joint with pelvic band is also there. Knee joints, it is important. These are the various types of knee joints: constant friction single axis knee joints, manual locking knee joints, polycentric knee joints, as I have told earlier, weight activated stance control knee joint, hydraulic knee joint, pneumatic knee joints, and microprocessor controlled knee joints. I'll skip through this because yeah, these are various types of knee joints. You can see constant friction knee joint, weight activated stance control. This is polycentric knee joint. This is most of the, this is very commonly used nowadays. It is not so expensive, and also it requires little bit less maintenance as compared to hydraulic or pneumatic joints. These are most commonly used nowadays. Polycentric for also called 4-bar linkage knee joints. Now shank and foot assembly endoskeletal. These are all shank and foot ankle assembly as same as the transtibial amputations. Now coming to hip disarticulation, the similar thing, only the hip joint is required in some cases, or in hip joint is required, and different types of joints are there. Canadian hip disarticulation prosthesis is the standard prosthesis for hip disarticulation, and weight bearing through the ischial tuberosity and the gluteal musculature as similar to the transfemoral prosthesis. I'll just let up. Coming to the energy expenditure, longer the residual lower limb, lower the energy cost of walking with a prosthesis. So energy cost related to the etiology of limb loss. So etiology of limb loss, patient with this vascular amputation expend more effort walking than those with traumatic amputation. It requires less energy with bilateral transtibial prosthesis than with a unilateral transfemoral prosthesis. Now, there are special considerations we need in pediatric amputee between 9 to 12 months of age. Transtibial PTB prosthesis with plastic laminate, supracondylar strap, sash foot. While in transfemoral, narrow medial laterally, ischial containment with no knee unit, suspension with Silesian belt, and knee unit until the knee unit at the age of 18 months. May require auxiliary suspension like waist belt or bilateral shoulder suspension in cases of pediatric amputee. New prosthesis annually till 5 years of age, and biannually till 12 years, and every 3 to 4 years till 21 years of age. In cases of bilateral limb loss, the lightweight prosthesis is required. Soft insert or flexible socket may be used to enhance the comfort. Ischial suspension also, suction suspension is using silicone slip is used most commonly. Yeah. Now coming to temporary prosthesis can be fitted as immediate post-operative on the operation table. Patient made to stand on the next day or walk in 3 to 4 days. Waist belt suspension is required. Sterile shock and cast socket is used. Adjustable pylon with foot ankle assembly. Prosthetic training is one of the most important component of prosthetic rehabilitation. Donning and doffing of prosthesis, inspect the residual limb for signs of skin breakdown, perform safe transfer, weight bearing with prosthesis, ambulation on the level surfaces, and training on stairs and uneven surfaces, and ramps and inclines is also very important. Okay, thank you.